I'm here today with Dr. Szeplaki, and thank you very much for joining me and agreeing to talk about PFA and FARAPULSE.
Thank you, John.
Can you just tell me a little bit about yourself, where you're from and what you do?
Yeah, so my name is Szeplaki. I'm originally from Hungary. I moved to Ireland in 2015 and now I live in Dublin and I work in a big matter private hospital.
The Emerald Isle, fantastic. Great, so can you just tell me about what your experience has been of the introduction of FARAPULSE in your clinical practice?
Yeah, so we launched the system in 2022 in April, so exactly a year ago. And so far the experience was quite good. We've done more than 300 cases so far.
Right.
There are 6 of us in the lab and everybody is using the system, which was quite unusual. Before, just one of the consultants were using cryo, for example. And the integration into the daily workflow was, I would say, seamless.
Very interesting, seamless. So just talk me through what the workflow looks like in your lab.
So in our lab, we use general anesthetic for all atrial fibrillation cases.
All of them.
We always do a CT scan before the procedure, and I think that's quite important because I don't want to go in blind to your left atrium. So knowing the anatomy is really important, and it helps with the PFA procedure as well.
In what way does it help?
You know the anatomy, and you can also see the side branches. And sometimes when you use the device and you want to slightly reposition the device, you can find a better side branch, for example.
Does that change the number of applications of PFA?
Not necessarily, but I think it changes the contact and it changes the quality of the procedure.
Right.
And secondly, you know the anatomy, and if there is a rare anatomical variation, then you can be prepared for that.
How consistent then is the procedure? Are you confident that you'll get through it in a particular time, a particular number of applications? What does that look like?
So typically we are aiming a pulmonary vein isolation for our first patients who have an ablation with us. And the procedure is quite consistent in time. So our average was around 40 minutes for a procedure, but you don't really see too much variation. So I would say typically the case is between 35 to 45 minutes.
Is that skin to skin, induction anesthesia?
Yeah, that's the skin to skin time. It doesn't include the anesthesia and doesn't really include the turnaround time.
So how many patients would you manage to?
Typically on a day we would go for 4 patients.
Do you think that that's an improvement in efficiency compared with previous approaches and technology?
Definitely, definitely. I think the time is very important and the timing of the procedure is very important, but you would never sacrifice safety, and I think that's the real huge benefit of using a PFA technology. In our experience, the complication rate was really low, and we didn't see those complications related to the phrenic nerves or even to the esophagus, which you want to really avoid in a pulmonary vein isolation. And as a side effect, the technology is really fast, and that's great because it allows us to plan our day a bit more appropriately. You can plan to do 2 or 3 short cases, and then you have a bit more time in the lab, and you can do more complex cases as well. So certainly, I think the volume has increased since we're using it, and the predictability as well.
That's great. So I'm picking up very clearly on the efficiency aspect, the safety aspect above all else. What about effectiveness?
Effectiveness, we don't have data on long term, but the acute effectiveness is really, really good. So all of the cases were successful.
Do you use any mapping?
Sometimes we do, and especially at the beginning of the journey, I think it was quite nice to use the 3D mapping to see the catheter. As you're aware, you can display it on the 3D mapping system platforms, and it allows you to learn the procedure properly. It helps quite a lot with the coaxiality and the alignment of the spines. Now we are not using mapping routinely, but we still do a lot of redo cases where I think mapping is essential.
So do you think the lesser use of mapping is a function of a learning curve, and is there a learning curve?
Yeah, definitely, definitely. Right now, I don't think for a standard pulmonary vein isolation I would routinely use the mapping, but if the integration happens, that might change. Because the only downside I see with the technology is the fluoroscopy time. So you're definitely increasing your exposure. And if you can reverse that by using a 3D mapping system and reduce your fluoroscopy times back to the gold standard.
Are you picking out particular types of patients? Are you doing persistent AF patients?
We do all comers, and we have quite a big population of persistent atrial fibrillation.
And you're using it as effectively in them, you think?
Yeah.
So what do you think the next big step is with PFA? It's the integration piece.
I think it's the integration piece. Certainly we're eager to see the long-term data on durability and outcomes. That would be great to see.
And is that posterior wall ablation that you're looking at, or what else?
We just started the Paradise trial, and we are enrolling all comers to the study. I don't do routinely posterior wall isolation for the first case. I try to limit my procedure as much as I can.
Okay.
But certainly if it's needed, then it can be very easily done by the catheter.
So that's a lot about great stuff with the physician experience and the clinical throughput. What about the patient experience?
The patient, and again, it was very interesting to see that the patients are not really complaining about the pericardial pain on the next morning. If you compare it to radio frequency or any kind of thermal source, I think the patients are leaving the hospital with some discomfort, and we don't see that in PFA patients.
Do you do day cases?
No, in our center, no.
Is that a reimbursement issue, or?
That's a reimbursement.
Okay, fantastic. So can you just give me a summary of what you think PFA means to your clinical practice, again, in terms of changes of how you manage atrial fibrillation ablation?
PFA is, I think, changed the way how we are looking at the things right now. 50% of our atrial fibrillation cases are done by PFA, and that was 100% RF in 2020, so it definitely changed.
Big difference.
Big difference. It's safe. It seems to be acutely very effective, and the patients tolerate the procedure very well.
Gabor, fantastic. Thank you very much. I've got a really good insight into how you work with this, and the contribution you're making is fantastic. So thank you, and thank you for speaking to me today.